comfortable?
Yes.
Well, I've been, when I was at DC, I was an executive assistant in several organizations there.
Just want to pet it.
Fundraiser for Nashville.
Can I take it home?
No.
I had my own professional sales series being either entrepreneurs that are ready to make pottery,
Yes.
nutrition, or whatever. But the administration just kills them.
A little leopard baby. That's his roar.
When they're executive size.
You know, they take care of it.
Yes.
Oh, until, for the zoo? Until they,
You know,
All kinds of issues with that, or just animals who are wanting.
Oh.
That you can take care of it, feed it, all that stuff.
oh no, this is real.
Oh, that's real.
Uh-huh.
Or, there's a factory
So cute.
What a little cry.
They just carry what they do.
I'll wait in here till you get back in case we're done.
As soon as they finish, I'll come back up.
Okay.
Okay.
And I just started
Uh-huh.
yesterday. So if you see me fumbling with some minutes, somebody else is gonna give you 50 minutes taker. I'm
Plenty of time
supposed
to
to
chat.
take in all the fun and
Because
excitement and get a sense
I
of
have everything memorized.
this because I'll be doing minutes for this in the future. So I'll be looking at your
Should probably at home in bed at night.
Ruby City,
Clock reading stuff.
here in Virginia.
No, I used to be.
I was
Well, good.
in, well, Northwest.
That's
Yeah.
good.
Well, I was up near the cathedral some. The last
I do my emails all the time.
Apartments was down, Glover, Glover Park, Glover Park? Glover
It's
Park.
been a long time. It's been,
Yeah, off of Wisconsin Avenue. I'm picturing it, but I can't, there was a ballpark there. And then, but I lived 14 years in Silver Spring, right outside of
So is there anything that
I always tell folks here in DC, you know,
you know about
I
this
never
league?
lived right in the district.
Oh, okay.
But, you know, when you're in the Beltway up there.
Or less stressful.
That's
usually easy.
That's funny, because I've
So,
heard that name in conjunction with
Except
this
for
meeting
people
like
with-
3 times today now.
Because
work with the Office of Personnel
I always
Management,
have reviewed everything at the
also
office, so.
doing background investigations for security clearances. First job out of college.
So who was still on the table there yesterday?
Yeah,
He is substitute chairing
Did
today.
a
Is that
1 month
right?
transition, I thought that maybe
Because
I could
Billy
stay
Kennedy, the
there.
new member,
Right.
was also the chair.
To the job as a head of the whole thing, so I was
Do
like,
you know who else will be here today?
but it was not for me.
No, I haven't heard, well, Duncan, Sumter from Appalachian.
Do this, that should be on a banking desk, I do nothing about banking, but here I was trying to recruit people for
Yeah.
banking jobs and so forth.
And you
He said,
could talk
"You've
your
got
language
the,
or-
he said, you've got the, well,
Pat
more or
McGinnis.
less, it really wasn't that hard. He said, you've got the skill sets.
That's everybody except
And
Carl.
I just, well, one
Carl's
of
no
them wasn't.
longer on the committee.
There you go.
I did it because financially I thought it would be a better position, but two, I wasn't real crazy about that, you know, they don't eat what you kill. And I'm a little more used to a steady paycheck. You know, I work hard.
Well, I wonder if Jesse
I'll give you your money's worth, but,
Well,
you know,
No,
I was
I
on
don't.
first month I was on the draw against commission, so
I'm not sure
that's
who all the
fine, but
applicants were.
that was only going to last for a couple of months, and then I would have been on my own. I have a feeling though, if I'd stuck it out another,
He said he was wanting to recommend someone
I
that
set the commission, and then I would probably end up
He's
staying
already-
up there because
Yeah.
I had a candidate who was,
That doesn't surprise me. I think he had extra
Made
time
it
scheduled to
through
sit and talk
the
to Rob and
second
Rachel afterwards, so
like,
I would imagine that they sat and made a
interviews
decision.
for management position in the bank. And I wondered why, because he had initially been very encouraging.
Uh-oh, it says we're supposed to be in the Eagle Room and we're in the Oakland Mike's room.
Mhm.
With Eagle Room right here.
That's not what
I'm,
mine
look-
says.
no, that's another committee. That's finance?
Oh.
Is it? Yeah. Yes. Well, that, you know what?
Okay,
That
thank
changed.
you. I'm not crazy.
You must have, no, you're, yeah, finance is in there now. We're here, we're
You
good.
think I'm crazy. You just
It's a
got a
good thing.
different
Yeah,
version.
that, somehow,
Finance is
yeah, you got
downstairs.
This is
a
not,
version before it's correct.
This is.
this is the executive.
No,
Was,
this is
should,
performance
should I go stand by the
Okay, okay.
elevator because you-
All right.
if
You're
you,
in the right
we
place.
All right.
didn't, we didn't see that sign.
Executive.
Wow, this is the truth. I've never been in.
Was there a sign?
There,
Yeah.
yeah, believe it or not.
I didn't see
Didn't
it.
see any sign.
I just walked
I've
around.
often wondered about that apartment
Jensen,
complex
go up
over
to
there,
the
whether they
12th
have
floor.
nice views and
Right, yeah.
they do.
So I walked
Yeah,
over
this is
to
the
the
first time
elevator.
I've been up this high in any part of Asheville.
Yeah.
Hey Jeff,
How are you?
I'm good. How are you?
Good.
Take that back, I have been in, what's it called, is it the Flatiron Building that's on Wall Street? I've been on one of the other, but I was not in the room that had a window.
Yeah.
Yeah, so,
You know, I went to a fundraiser this past weekend at the top of the Battery Park Apartments. That's got the best view in Asheville, by a long shot. It's actually on the top of the hill, and you can see everything.
that's great.
It's really,
Wow.
but it's you know, it's subsidized housing, so it's I mean, normally you don't even have anything there. You know, the residents who live there. It's interesting. Yeah, I mean, you can see the Battery Park Hotel. It's higher than anything else.
Yeah,
Or Battery Park Hotel.
so is that the one that they renovated a year or two ago?
I think they may renovated the bottom floor,
Okay,
but I don't know that they did anything underneath.
or it might have been this closer one, kind of right in front of it. Right there at the Civic Center, that might
Right.
have been the one.
That one I know has been,
The Indigo Inn? No, that's the
Indigo Inn's
beige
brand
color
new.
one.
it's that beige one, and it's.
Yeah,
But the red one's the one I was thinking maybe here.
that they renovated. Is that the one that the little Havana used to be in, or?
Yeah, well, that's Battery Park.
Oh, okay, that one.
That's right underneath there.
Oh, okay.
I keep telling my wife, we need to move downtown, like, you know, they wouldn't have to go have a yard, and you know, she said, okay, well, you just have to promise to take the dogs for a walk every night, because I'm not going out late at night.
Right,
I said, well, it'd be good for you to get that exercise.
You'd run.
I haven't been able to wear her down either, usually I can, but in this case, I've been losing.
Moved to downtown. Wow.
I like
We were
living
talking just
places
a
that you don't
moment
have to
ago about
drive.
this new Brasilia Steakhouse, have you tried that in Dr. Heck?
What's
I
that?
lived like
This
many
Brazilian
places where you
steakhouse?
can't hear your neighbor.
You know,
That house.
I've eaten I've had many
But
trips
when-
to
so when I
Central
went
South
to
America, and I've been to
Germany,
those,
they just all walk.
but the
So there's
the
not
whole
a lot of
premise is you eat
cars,
as much
they're not
as you
noisy.
can.
Right,
But I can't eat that much at
Yeah,
night, so
yeah.
I feel like I'm,
How
and if I do, I don't like the way I feel,
Right,
so.
right, yeah. It's, I wanted to try it, and I haven't heard anybody that's actually,
Um,
well,
No.
I'll take that back, I have heard one person that has, but,
Yeah,
I wouldn't.
I've just not gotten, you know, I like smaller, my favorite place here is, I love Bouchon's, I love the French
I've
restaurant.
eaten there once and I enjoyed it.
Yeah.
Had the kids with me, they weren't,
Oh, gosh.
they weren't crazy about anything except they did like the French fries. Well, they don't call them French fries, it's.
Pommes frites.
Yeah, right. They have a little,
Aioli, like a basil aioli sauce.
right, but they also have
So,
some herbs
Ray,
on
Jill
the
didn't mention
fries, so.
Yeah, yeah, they
anybody
do.
else
It's a
not
little
coming
tiny,
to
it's
the
almost-
right?
You almost
Yeah.
don't see
Normally,
it.
Pat
They
McGinnis and
My
Duncan
kids are,
Sumter.
my kids have,
she
like,
never heard
the
from
the more
Duncan.
expensive, the more they like it.
Okay.
That's great, 'cause I mean, they have the taste, my kids.
Pat, I thought was gonna be
How
here.
old are they?
Mine are only 10 and 11, Justin will be
Oh, okay.
12 next week, but they're
passengers down there a little bit longer, but like you said, I think they'll.
Wendy's.
Chicken nuggets
Yeah.
and hamburgers and grilled cheese. And
Right.
I can't get them to eat anything either nutritious or,
Yeah.
if you will, I don't want to say exotic, but I mean, for Mary and French restaurant is exotic to them.
Yeah, I'm sure.
But-
I don't know if you wanna start, even though it's just the two of you.
Do you know
We
about
didn't,
Dunkin'?
we don't know about Duncan.
Sure, I mean, if you want.
Well,
Are you Dr. Heck?
Yes.
Hi, I'm Ray Ratliff. I'm the new executive assistant.
Oh,
So
nice to meet you.
I'm pretending to take minutes today, but
Oh,
but
no,
Amy,
you'll-
this is
Amy,
You'll do terrific.
Amy's going
Amy
to-
Nye. She is actually the admin support in quality and integrity operations. So she's gonna take the minutes today.
What about Pat? Do
We
know?
didn't realize we'd luck up and have Ray already employed.
Well, since
Right.
yesterday.
Yeah. Okay.
What about Pat Venus? Is she?
She's, I think she's coming, but it's,
Yeah, it's 3:07 afternoon. Sorry, I wasn't paying attention at the time. I'm sorry. Well, you don't need it.
well, I'll leave it up to you.
We'll call the meeting to order. Could let the minutes reflect that Mr. Kennedy's not present, so I'll be chairing today. The first item on the agenda is approval of the agenda. I have a motion to approve the agenda.
So-
I have a motion, and yes, I'll second that even as chair, since we have no one else. All in favor say aye.
Aye.
No, none to oppose, it's unanimous. Minutes, need some time to look at those, or,
I finally got the chance to read everything in advance today, so
Good.
I forget the minutes and we move that we accept it.
okay, the motion, and I'll second that. All in favor say aye. It's unanimous. The next item on the agenda will be the monthly reports, starting with the performance improvement grid, and I'll turn it over to Julie.
Okay, we have our performance improvement grid, which is where the document that the system performance team uses to track our corrective actions. Now, we have no corrective actions from the monthly report because all of those have met the standard for a period of a minimum of 6 months, so they all rolled off. So we have that, there's no new information on here. We continue to have the access to care measures that need to be improved. But I can report that we received, let's see, page 3, our IMT items. I'm about to turn in the final on all of those, and they will be completed. On page 4, the external quality review, we got our initial report back, and out of the initial items, we have 9 that we have to submit additional information. So, so that's good news, and we'll be submitting that on May 4th. And that is all that's included, even though this is a thick document, that's all that's there. We got our response from the external quality review after we'd already submitted our documentation. Otherwise, we could have deleted some of those pages. For the Department of Health and Human Services monthly monitoring report, we're reviewing the March data, and we met or exceeded all of the standards for the March data. I tried to put page numbers on it, but I could not get them in there. because it was a protected document. But I'll keep working on it. So the second page though, which is the first page of the Medicaid-only data, even though we had a high October in the EDs, November and December were low. It usually is lower in November and December because of the holidays. We have begun our collaborative ED visit project with the comprehensive providers. So we are working with those 5 providers. What we are doing is every month we meet with them and we are giving them a list of the individuals who were admitted during the previous month who are active consumers of that provider's services, so that they can backtrack and see what happened if in fact it was something they could have prevented or not. So hopefully, by providing them with this information, the ED admits will go down. And once we've started, once we've gotten settled with the comprehensive providers doing this project, we'll start to do a look and see who else has high numbers reporting to the ED, and we'll give them the information also.
And intuitively, do those 5 providers feel like there are things that they can do that actually would reduce admissions or readmissions?
We've only had the first meeting where we gave them the data, and we haven't met with them to see how they followed up and what they found when they looked at them. So I don't know, I don't see why they wouldn't think that, because some of them are the Assertive Community Treatment Team Services, which is a 24-hour wraparound service, and some of them are other high-level services that they should be able to respond and divert from the ED.
Yeah.
Because the ACT teams have psychiatrists on them too, so if it's a
Right.
medication issue, there should be a way, and nurses, of addressing that before it gets to the ED level.
And do we have any way of looking at whether those who would enroll in the ACT teams actually have fewer admissions, fewer readmissions? Do we have any way of tracking that at this point? That those who are not part of ACT teams?
Well, we could pull paid claims and then do a match of Medicaid ID, and then those who have paid claims for ACT and ED visits, compare those who don't have ACT and have ED visits.
You know, I really did give it some thought. Maybe you're going to regret me giving some thought on this, but I looked at this this same thing, the comparative report of all the LMEs.
The February data?
Yeah, and one of the things that's really fascinating to me, you know, again related to this, you know, is percent of admissions, Medicaid admissions as percent of people receiving services across the state is considering that N is so large, there's huge variability. I mean, as much as 50% below the mean and 50% above the mean.
For the ED visits?
Well, first of all, just the members receiving services.
For Medicaid or the state funds?
For Medicaid.
Okay.
So if you look on page 7 of this report, I know I'm jumping around, but if you look on page 7 of this report, you look at the variation in the rate of members receiving as low as 30 Medicaid recipients per 1,000 receiving services and 76 per 1,000 is a huge difference. And then, you know, it's all across the board too, so if you look at substance abuse admissions or readmissions even, there's this remarkable variability. And so, you know, you might make that conclusion, but there's a bunch of things you could draw some conclusions about it. But we don't have the data to support that, but, you know, I think sometimes we think maybe it's services or access to services that make for that variability. But I wonder if it's, my guess is it's probably something else. It may be poverty rates, or it may be poor schools, or poor school attendance, or poor school performance, or lack of access to primary care, or lack of access to, you know, I don't know, any number of services, for instance. And I'm just wondering, like, how could we get at that answer statewide, because we may be barking up the wrong tree of all the things that we're trying to do. It'd be interesting to be able to use larger databases to see that.
Well, there is a quality management directors forum that includes the all of the LME-MCOs, and I could probably have our QM director suggest a statewide LME-MCO collaborative performance improvement project. But I mean, that we would have to see if everybody wanted to jump on board or not.
Well, I wonder, like, so this data, to all the, I'm sorry to be a diversion too, but I'm trying to be helpful. Do all the LMEs use the same service for data collection? Is it all going the same? Everybody uses the same vendor for?
No.
No.
And not even, and even if they did, these are not automated reports, so each LME-MCO pulls them themselves and could massage the data if they chose.
Oh, really? So there's no information management system that has the raw data in it?
No, but when MC Tracks starts working properly, then the some of the measures can be pulled from the encounter data, and then that will be the state pulling the data, not MCOs, and they'll pull it from the data that the MCOs have submitted, the encounter data from paid claims.
So then there will be raw data.
That's pulled all the same way. For,
So we don't
for
know-
certain measures,
Okay.
for certain measures such as paid claims.
Yeah. But we don't even know whether NC Tracks or Ethiopia, or we don't know if this, or the state HIE even has what the existence of that is even for,
Well, it got certified.
yeah. So, you know, if you
Well, I have a
You
question.
can look at the measures and tell which ones are suspect. For instance, when we used to look at the call center and the numbers added up to more than 100%, you knew that the LME-MCO wasn't pulling it properly, because it really should add up to less than 100% between calls answered in under 30 seconds and abandoned calls. The most that should equal is 100%.
So is there not an independent auditing process that occurs for the data?
Theoretically there, but not for this. It's only for the performance improvement projects. The external quality review organization validates the performance improvement projects, but not the typical performance data. You had a question, Pat?
Yeah, when you're over here, we're looking at ED admits, and I'm assuming somebody waiting on a bed has at least been admitted to the ED. If they're in the ED, they're admitted to the ED.
Well, there is no such, truly it should be ED visit.
Okay. Well, is there anywhere where number of days, maybe statewide and then Smoky, that somebody spends in an ED waiting for a bed?
We could pull that for Smoky, but we couldn't pull it for the other
Anybody else?
LMUCOs.
Because I've heard from some folks in the last month or so from the very far western part of the state, and I've basically heard that at least in one situation, weeks turned into months.
Well, there is a situation that was like that. The good news is that that was a while back, and that person was discharged with wraparound services, and in the past 6 months has had only one visit to the ED that lasted only 3 days, as opposed to his frequent visits previously, and long because hospitals considered him difficult to place.
Well, I guess it's, I mean, I really didn't, I got a phone call, but I really didn't pick back up for the person. I wasn't voted, but I didn't know if it was an adult, a child, senior citizen, male or female, you know.
The 88 days,
Yeah,
it was a young man.
over 18 or under 18.
Over.
Okay, just curious.
Julia, I'm sorry, one other question about this, on this other issue. Do you also, are you also uncertain about the integrity of the data related to hospital admissions and readmissions and utilization of services across the LMEs?
Yes.
Okay. What a shame.
The problem is, until recently, and even recently, I believe what it is that the LME MCOs for readmission data were using different dates of service. So some were using the previous admission date. And so if the previous admission date, let's just say I was admitted on May 1st and I stayed there 14 days, so I was discharged on May 15th
Right.
and admitted on June 3rd.
Uh-huh.
If I was using the previous admission date, that wouldn't be counted as a readmit.
Because it's more than 30 days. Yeah.
But you're supposed to use the discharge
Of course.
date, which is what we're using. Yes, so yes, that's the long answer. And the short answer is yes.
Boy, what a shame. So you gather all this data and it's not even reliable, because it would be your best tool for planning.
Now, our data within Smoky is reliable. Our
Right.
trends are reliable and how we're looking at those. And they are working in the Quality Management Directors Forum to make sure that everybody is reporting the data in the same way.
Right.
Hopefully, if we reduce the number of LME MCOs, there will be more data integrity, because there will be fewer hands in the pot and everybody will agree to pull their data the same way.
Yeah. I mean, technically that could, if you had even just a mediocre data system, those calculations would all be automated. It wouldn't be subject for any interpretation because it would be based on claims data. So I don't know. There's a lot of room for improvement, I guess.
There is. There is.
All right.
So, so that was the February data. I don't know if there's anything else that you want to talk about in the LME MCO comparison report. There's really nothing else to talk about in the March data for the DHHS monthly monitoring report, because we met all our standards and our measures are looking good, and we're working on the ones that we just started working on, the ones where we want to see improvement, and it'll be a few months before we see any impact.
So just theoretically, so you've got a threefold difference between the lowest and the highest utilization rates of members. does that translate into the capitation rate? You know what I'm asking?
Yes,
So on
I
page-
do.
On page 7,
No, because it's not the number of unique individuals served. Your capitation rate is basically your paid claims divided by your member months. So it's more about the number of people who are eligible for services, not the number of people that use services, except to compare your paid claims, which are the number of people that use services. And then it's based on, they divide it down into the number of eligibles, not even down to the number of people that actually use services.
so theoretically, if you had a perfect system, you lived in utopia, and nobody used the services, you'd still get the same capitation rate.
No, because we wouldn't be paying claims.
Oh, that, okay, yeah, you're right, so it's, okay. Okay.
So the ones that have a higher penetration rate are serving more people with the money they get, which is a good thing. Pat, did you have any questions about the March data or any other questions about the February comparison?
No.
Okay. So we'll move to the quarterly reports then, if that's okay with you,
Yes.
Michael. The first one on our agenda is the backup staffing report, and it's the one that looks like this. It's very pretty.
Very amazing colors.
But it's a little disturbing. So this is the yellow line is the number of reports, and the purple line is the number of hours. So it looks like, if you do the math, that you have about a little under 4 hours per report. If you look at, it might be about 3.5. So every report accounts for approximately 3.5 hours of service. And if you go to page 2, oops, they didn't put page numbers. Incidents by service type, you will see the most missed are personal care and in-home skill building.
Excuse me for my ignorance, but what's skill building?
Well, so probably in this service, these are innovation services, so these are persons with diagnosis of intellectual or developmental disability. So the skill building is most like brushing your teeth, getting dressed.
So OTPT kind of
Maybe
services.
knowing how to operate a washing machine, how
Okay.
to brush your shawl.
Yeah, okay. And what devices they may need to help them do that? Yeah.
The devices that they need to help them do that could be paid under either augmentative technologies or home modifications.
Right.
You know, the sad thing about this, when you're talking about these personal care services and stuff, I'll have friends and peers that would love to break into doing some of this part-time and can't seem to get a foot in the door. I mean, and they would love to start by being backup staff, but there's evidently no place to go to start. You're either in it or you're not.
Oh, I don't know. I mean, there are provider agencies. We could look at the provider agencies that have the most issues with staffing and
So, you
refer
know, I
them
had
to
somebody talk
those.
to me about that yesterday, and I said, well, you know, there is such a thing as on-the-job training, or there should be. So, might be something to look at.
So, yes, because when you go to the third page, the most common reason for trained staff unavailable, seeking qualified staff.
We're doing something wrong there, I think.
Or are they typically PT, OT, type of, I mean, that speech pathology?
No,
We're talking about.
they're talking about paraprofessionals who are high school graduates
Yeah, oh, okay, so
with
more
trainings, more like CNAs.
home health aides, okay. And CNAs, okay.
You know, Goodwill Industries is training that in
Would
Patton
you
Avenue
not pick up
office.
the
Their
prescription
training
last year?
center, they're training for
cool.
CNAs and stuff.
Cool.
Well, I can tell you across the region, I'm speaking for Mayheck and Mission,
They have,
there's a
I'm just,
there's a crisis shortage of CNAs, CMAs. I mean, there are more positions available than there ever have been. We can't get enough. So,
Are they paying any better than they were?
so the rates for, I mean, payment is typically lower than most healthcare professionals, I mean, certainly lower than nurses.
I mean,
But,
I knew that, but I mean, several years ago when I worked as a healthcare tech, I declined to take CNA training because I would have made less money as a CNA than I was making as a healthcare tech.
yeah, well, yeah, typically that's the case, but I think, you know, usually when the economy's good, those lower paying jobs become less attractive, so, I think that's what we're seeing. So this is not surprising. 208 is a lot of, I don't know how many individuals that means, but.
That's right, we don't, because that's 208 incident reports,
Right,
and 10 of them could be for the same person. Yeah.
Yeah.
So, that is the story about backup staffing for the innovation services.
So you were saying bad news, but it looks like it's not that different than other months.
No,
Just more bad news.
yes.
Okay.
But
my apologies.
this staff is, this is the ones that we have looked at, and to be honest, this staff, there are only 2 staff doing all the incident reports, and they have a backlog of incidents. So I forgot to ask David if that meant that when we give a report, it's possible that that it might not be a true number, because I know there are 2,000 backup staffing incident reports in the backlog.
So basically, when there's nobody to back somebody up, an incident report gets filed.
For certain services, only certain services.
Because it means the client's going without care.
The next quarterly report we have is the innovations dashboard, and it's the tables that look like this. So, we still, if we look at table number 1, we still haven't gotten everyone placed into an innovation slot who has been identified for an innovation slot, and this has to do with the requirement for a level of care and a psychological evaluation. We don't have many providers who provide that, and so it's hard to get them in there, and then if they miss an appointment, to reschedule the appointment. But we are doing apparently better than the rest of the state, other than Cardinal Innovations, who's been doing this for 8 years. So that was good news. Still, we want those 23 other individuals who need to get into slots, we want them in slots. We are hiring a position called a Registry of Unmet Needs Coordinator that will hopefully enable us to get this turnaround more quickly in the coming year, because we get additional waiver slots on August 1st. So we have to start identifying those people in May. because it takes that long to get appointments and evaluations and that sort of thing. But the good news is, if you look toward, table 7, of the people waiting for services, of the 1,300 people waiting for slots or services, there are 849 receiving services. So the people who are waiting, so we have 956 on the, that are potentially eligible, which means that's the registry of unmet needs. Of those individuals, 849 are receiving at least respite and community guide.
Some kind of care.
Which one of these groups would cover transitional apartments and things like Oakview? Would that be community-based ICF, IID, or?
No, I don't know what Oakview is, so is that?
It's where IDD and some other consumers, they have their own apartments, but they have a day staff.
That would
And they're
come
apart-
under NC Innovations, it's not an ICF. If they have innovations funds, but if they have state funds, they might be a different funding source. I don't know what else you would want to look at here. We have 333 relatives as providers, so of our 1,600 innovations, 300 of those individuals have a family member as a paid support.
And a family member is not the same as a household member, is it?
No, not necessarily. Okay. The investigation oversight report. Well, we also have the slides actually of the March data, but we talked about the March data. The investigation oversight report has a top page like that's narrative, okay. So that is a summary of everything that comes to our Investigation and Program Integrity Oversight Committee. So it tells you about all of our non-routine monitoring activities. So anything that's an investigation or a monitoring that is non-routine. We've seen this a few times, so we have the number of referrals, the source of referrals, still primarily Smoky staff members. The types of, or the departments from whom the internal referrals come. Care coordination, they see the consumers more often, they might refer for an investigation based on something they observe. Clinical operations is our prior authorization and utilization management department, so if they see something coming through as a request for service and there are things in there that catch their eye, they refer. Provider network, those are primarily routine monitorings that turn into a request for an actual investigation, which would be a more in-depth monitoring, either for quality of care or fraud or program abuse. We have some internal referrals from QIO and PI. Those are primarily data mining. So we look at paid claims and look for patterns that are suspicious. QM, those referrals primarily come from grievances. That's pretty much risk management. Those referrals would come from our critical incident review. So if we review a report of a critical incident and have some issues with it, we would refer for an investigation.
And how come circus listed there separately?
Oh, I don't know. Maybe it's before it gets to CERC. I'll ask David or Andrew. So, I don't know if you have any questions about the investigations.
How confident are you in the thoroughness of those? It surprises me that this position on 71 out of 192 have no findings at all.
They're very thorough investigations. I think that, there, we have staff still learning how to discern what needs technical assistance versus what needs their supervisor to talk with a provider versus what is truly an investigation.
How many investigators does somebody pay?
Well, people with the title investigator, 7. We have 7 investigators in the program integrity department. However, in the provider network department, there are, I believe, 13 that participate in focused monitoring and routine monitoring. And focused monitoring is considered an investigation. 3 of those are clinicians who look at the clinical side of things, and I don't know what the other provider monitoring staff, I don't know what the requirements are, but for post-payment review, you have to be a clinician. Some of the others may very well be licensed clinicians also. So the good news is we don't suspect as much fraud or see as much suspected fraud as the eastern part of the state. But we do see some, and we turn that over, and we actually, every investigation that we've referred to DMA program integrity and the medicated criminal investigation division has been accepted. So our staff does a really good job of really gleaning what could be fraud. So the last item on here, F, would be the consumer perception of care. So what you have here are 2 documents, and it's good that we have 15 minutes. I wanted to spend more time on this. You have the actual report that came out from the Department of Health and Human Services. This is called the Consumer Perception of Care, which is essentially a satisfaction survey. The state tells, and this is done by actually DMH DDSAS, so it's not done by DMA, the Medicaid provider. May include Medicaid recipients, but it is only mental health and substance abuse. It is not persons with IDD unless they have a co-occurring illness and they are actually going to a center for a mental health appointment. It is about their mental health services. The state sends the LME MCO the number of surveys that they need completed. They send us the number of survey, the survey tool, and then the LME MCO distributes that to a certain number of providers. That
At the time of care or after the time, after care?
They that's a good question. See, here's where there is a wide disparity on how this is administered. Because in the eastern counties at East Carolina Behavioral Health, the LME MCO staff actually go to the provider agencies and the LME MCO staff hand these out and get them. And I don't know if it's when they walk in the door or when they're leaving services. That could have a huge difference on how it's so what we're told to do is give them to providers, and providers are to administer them. So whether they're handed out by the receptionist when they come in, or the clinician when they're in session, or the receptionist when they leave, there's no standard way, no.
Wow.
That's not good.
No. Now,
I mean, from my understanding of patient satisfaction data, that the most accurate way to do it is after the care is provided, so it can be done in an anonymous environment or a safe environment, rather than have it given by and turned into the very people whom you're
Getting services.
evaluating.
right, now, it is, when it is, and we are talking, because of our, actually, there's good news and there's bad news. There's high satisfaction across
Yeah.
the state.
Mhm.
That's the good news. The bad news is, even though there's high satisfaction, Smoky performed lower than the state average in most cases. So your second smaller paper, that is our analysis of the bigger report. It compares the answers to our 2013 survey, and it compares our 2014 responses to the statewide average for 2014. Now what I was going to say is that there are 3 types of surveys. There's one for adult MHS or SA consumers. There is one for youth MHSA consumers, and those are adolescents. And there is one for parents to fill out about child services. So you have the three different types of surveys. If you look at our analysis of this, when we look at the adult surveys, the number of positive responses for the adult survey, we only exceeded our 2013 in one area, treatment planning, and that was the area in which we met the average for the responses across the state average.
Well,
Every other area, even though is good, I mean, 88% satisfaction is good, we still dropped 4 points from the previous year, and we're 3 points lower than the state average.
But given the denominator, the question in my mind is that statistically significant? You know,
Oh,
I mean,
no.
There aren't confidence intervals or p-values or
Oh,
anything like
no.
that, trying to validate the
No,
integrity, I mean, the interpretation of it.
because
They look the same to me.
we have a adult, we had to do, they didn't put the total, and the required amount was about 800.
Yeah,
But we have, that's in
it
it,
looks like in the 400s.
we had, almost 700 responded, almost 700, but not quite. So we were required to get, it looks about 800 and almost.
But that's-
However, I don't know how many individuals are seen in a month. But my guess would be, well, I'm not gonna guess, because we see, if you look at our numbers on the, we could go back and compare on this thing. Individuals served, so we have, in Medicaid, individuals served, 9,000, almost 10,000 receiving
Yeah.
Medicaid, and 1,500 receiving substance abuse for Medicaid services, and then for state services, we have a total of 2,700 and 1,000, so 3,800. So we're looking at, and we don't know how many of those are adults or children, but we're looking at for
20%.
over 15,000
Yeah,
seen in a month,
yeah.
and 800. So let's say 16, is that 20%?
Yeah.
800 of 16,000?
No, it wouldn't be that much.
2%. And so that's not
5%.
5%, it's not statistically significant would be my guess. But I don't know. I haven't taken some
Yeah, I mean-
stats in a long time.
I mean, that's the,
But I could ask my staff, they would tell me.
yeah, I mean, I think those are increasingly, as I see all this medical data, we're not applying enough vigorous statistical analysis to determine whether the differences we see are really that significant or not.
We aren't, and I read a little brief Kaiser Permanente paper that people aren't actually choosing on the basis of quality or satisfaction either yet, like they should.
Well, only if the data's good,
Mhm.
only if the interpretation of the data is good.
Oh.
I mean, that's a lot of the problem.
Mhm.
I guess the one thing that does concern me a little bit though is that we do see a little bit of a pattern. Either we need to be rocking the boat with the other MCOs to get the data more consistent, or we need to figure out why there's several of these where we're several times above, for example, parent survey general satisfaction, 1.6% average, 5.8% is ours. Now again, it's not that that's a huge number, but the fact that we're that much more above the others on a fair number of these does concern me a little bit. And again, I don't know whether it's the reporting differences across the state. Although it would be hard to say, or let's say hard to say, but it might be a stretch to say that out of all the MCOs, we're the only one that looks like.
What
shows
page
that
are you, you're in the
much.
DHHS report?
Yes.
And what page are you on?
Well, I mean, that's, on that particular one, it's page 21.
Yeah.
The general satisfaction. And if you look at the use survey on general satisfaction, it's similar. It's 2.8% statewide, 5.4 overall. But we're the only one that's that much above. On the youth, the closest one is 4%, and on the adults, the
For
closest
the negative
one is-
scores?
Right, on the negative, that's what I was
We're
thinking.
pretty high compared to everybody else.
And oddly enough, in both, excuse me,
We're high, but I think your point is, that's only 5 people.
Mhm.
well, yeah.
Or, I mean, one of
right,
it, it's
and-
5 people
Yeah,
out of 16,000 that are served in a month.
right, and I'm not saying it's statistically significant, but it does raise an issue if it was, because they're looking at access, satisfaction, treatment outcomes, and all of that. We seem to be a little higher on several levels.
Mm-hmm.
I'm not trying to make a big issue out of it, I'm just saying it does raise a little flag in my mind. But now, this is not really about the LME's performance.
Correct,
It's
there are a
about-
couple of questions about the LME, but yes.
Right, but for the most part, it's about our providers.
Yes.
And so, and the reason I bring it up is because if we have the data, and I don't know we do, for example, when you're talking about limited numbers like that, do we know, for example, if, of course we can't because it's anonymous, right? We don't have access to know which provider worked with the people that gave the negative scores, right?
This year, last year, we do not, but we are going to administer the survey differently this year. And we have a small group of people working on how that's going to be administered. So I'm going to, they probably already know that you get better outcomes after the care is provided, but I'm just gonna make sure they know. And I don't know whether we are going to get our peer specialists to help us. But we, depending on how we do it this year, we may be able to tell by provider what the results are.
To me, that would be the best thing to happen, because when you're dealing with that small of numbers, you may very well find out that they're all coming from two providers.
If you could have a geographic location question, are you from one of these counties? Or one of these regions?
We get a lot of pushback from providers about individual patient satisfaction scores, and their complaints are generally that the number is too small, the number surveyed are too small. Secondly, there are certainly some populations of patients who skew the results. So if you have a high percentage of people who are substance abusers,
Right.
they're unhappy sometimes because you don't give them what they want.
Right,
And no matter how respectful or responsive you are,
right.
the not getting the prescription trumps everything else.
Right.
So it's a huge area of dissatisfaction for providers with small numbers of surveys. And I'm not saying that you shouldn't do it, but it is one of those areas of great consternation for providers.
We don't have a choice. We actually
Right,
have
right,
to do
exactly.
it.
But I bet you'll get some complaints or some pushback.
The other question I would have is, and I agree with what Dr. Hicks said, there are groups of types of patients that might tend to fill it out differently. But if you have multiple providers within that same group,
And then there's a
a
variation.
difference.
Yeah.
That's when you say, okay, what are these folks doing that, you can look at that either way. What are these folks over here doing that this one's not?
Right.
Or what are they doing that
Right.
is causing an issue?
Right.
It occurs to me now, do I understand correctly, even though the state mandates it and they say you have to have this minimum, there's nothing to say that we couldn't hand out more of them? Or does the state say there's a maximum number for you to give out?
We could hand out more.
But it seems like if our concern is that sample size is an issue, then if we've got the option, if you give out more, then you might see, I don't know how that would affect people.
There are two different, there are a couple different ways that we could do it. We could, if we did it by a few number of providers and actually compared the number of surveys given to the number of persons seen in that month, you might come up with a more statistically significant number because your denominator would be smaller. And then we could do it by provider. Then we wouldn't, because certainly we did not give it out to all providers. And so really, my saying that there are that many persons served, well, that's the only comparison we have, because we don't know how many persons were served by the providers who gave out the surveys. So, I wanted to be a little more thoughtful in how we gave out these surveys this time, and the small work group is going to give suggestions in the surveys. We haven't received them yet, but the time frame for giving out, for doing the survey is mid-May through mid-June. So we're doing our planning right now. And hopefully, we can impact this by doing it in a more thoughtful manner. at least we will know that all surveys were given out either before the service or after the service, or, we'll have some knowledge about how the survey was distributed this time, whereas we have no idea for last year or the year before.
What's the message you're sending to the providers about the results of this?
Well, we just gave the results to our Provider Advisory Council on the 18th of April for them to look at, and the message, we'll have the discussion in May. And basically, it's, you're not performing as well as other providers in the state. And
I think it has to be that way. I mean, because, a minute ago I was talking negative numbers, but because you've also got neutral and positive, if you look at the flip side of that, it's not that we got a lot of neutral, on general satisfaction, for example, the state average is 92%, ours is 81. So it's not that we have
No.
just the issue on the negative side, we have it on the positive side too.
right,
Um,
right. It's that same old, we have lower positive scores and higher negative scores.
Right. Yeah, I mean, if the negative were just pulling from the neutral, it'd be different. But if,
Over here, when you talk about the physical health, we don't seem to be doing as good as most of them in other regions.
For adults,
Yes.
I looked at that. What page are you on?
Well, I just started looking and glanced through all of them, and, we're just, 37% selected fair or poor as, their health.
Well, see, that's another thing that could actually impact the other scores. I don't know.
And when you talk about, was your mental health not good, average days, we have the highest number, 13.2.
I don't know what page you're on,
Okay,
so I
I'm
can't.
on page 34 of 38.
Okay. Thank you.
It seemed like up there on that, we have the highest number of days where they said their physical health was not good and their mental health was not good. I just wonder what we've got going on that other folks are doing a little better at. Is it access or?
This is a small number of people, so, depending on what types of providers administer this, so if you have it, selecting your provider, you're going to get a different, and we use comprehensive providers, and they provide services like ACT and CST, and they serve individuals who have more severe mental illness or substance use. You're going to get possibly those answers from those in these higher rates of poor mental health and poor physical health from those individuals as compared to somebody who's seeing an outpatient clinic and doing somebody who needs only outpatient therapy, if that makes sense. So I am not well informed about this, but that's what I was saying, we'll be better informed this next year because we'll know who we gave this to. We've just been handing it out to providers and we don't know who they gave it to.
So let me make sure I understood the number you used a minute ago. was with 15,000 left there, you said that was monthly.
I was just doing a quick look of 1 month's total Medicaid and state-funded service recipients, because we do an unduplicated count of people who use services in a month.
And for those of you who know more about statistics than I, what do you think would be a statistically significant?
Oh, I don't know, I would
number
have
of
to ask my staff.
You actually have to do calculations based on a number of factors, which would include your response rate, the type of question you're answering, the display of
and
differences.
Right, and that's true too.
It's on a Likert scale, how many differences there are.
I guess I would like to see, I'm just ballparking here, but I'd like to see us hand out at least 10% in the future. I mean, that'd be about double what we're handing out now.
Yeah.
But I think at least that, to me, because I don't think we're gonna get at the things we really need to get at if we don't do at least that. I know that's a lot of extra work, but in another way, it's not, because it may mean going to more providers. But you're not individually handing out every single one of those, are you, Artie?
No, we are.
Right, so, so if it's not necessary for a Smoky staff person to individually hand out every one of those surveys, then just going to more providers and handing out more surveys wouldn't seem like it would, am I wrong? Would that be adding a lot of work?
I don't think so.
But, and I don't know what number to pick, I mean,
Well,
it needs to be statistically significant.
I mean, that's what you're really wanting.
Right.
What you're wanting to see is some statistical calculation at the end of the
Right.
survey. So when we see this, is this statistically significant? If so, by how much? That would be helpful. And it would only be helpful too if there was some actionable course as a result of doing the work, and
Well, and I think that's why it also needs to drill down to the level of provider,
Yeah.
to me personally. Now, then the other piece is, how does that compare with the state? Well, unless we know that there's consistency across the state, then I don't think we're ever gonna get that
Well-
piece. But if we at least could say, I mean, if we're already saying we're not sure it's statistically significant, if we're not getting consistent numbers across the state, then this is kind of useless in one sense. But if we could get the numbers up to make them statistically significant, then regardless of what the state did, I mean, the other LME MCOs, then we could use it for our own purposes.
Yeah.
To say, okay, are we finding that one provider in substance abuse areas is doing worse than the others? Or if we find that overall this particular service seems to have an issue, then you could look at, well, is it because the type of client that they're serving, as you mentioned, or you could say, is it that something each of these providers is doing, or maybe that they're not doing, or that they are doing, you know what I'm saying?
The one thing that's positive about your suggestion about giving the data to individual providers is statistically significant or not. It's a key element of process improvement, because if you're the physician and you see all your colleagues listing there, of course, the idea is to make the data transparent. So, you have all your colleagues across the region, and you're sitting there, and you're at the bottom of the list. You're gonna really work hard to make that difference. And it doesn't work with all types of professionals, but with healthcare professionals, it actually works pretty well just to share data with people.
and I know we're, that's 410, but I'd like, if it's okay, I'd like to make a motion that, I know you're working on it, but just to formalize it, that we do our best to have this next group be statistically significant, and that it hit at least the majority of our providers, so that we're getting a good cross-section.
We have 800 some providers.
Well, I mean, let me rephrase that, I guess I should say. Where the majority of your clients are receiving services, that's the better way to say it. Because if you have a provider that's only seeing one or two clients, but if you're hitting enough of those providers that you're getting the majority of your clients, then that's what I'm going after.
Mhm.
What you're asking is you would like to see a calculation of statistical significance in the data, because, I mean, if this is already statistically significant, at least as far as comparing across regions, I mean, in my mind, if that work had been like a statistical calculation, I'd probably be satisfied if it was a lower number, if it was a low number. But I don't know that it is or not. So that would be, it would be the easiest thing. I mean, your folks could probably do that. You can even make some statistical calculations on Excel. You can do that. Or if they had any, like whatever training app, I'm sure they could do this. But it would be the simplest way. And then the follow-up to that is, if it's not statistically significant, what can be done? How much more would the sample size need to be increased in order to make it so?
Right. And I guess part of that motion would be to say, if it's just right on the border, let's just get it on up there to make sure. Because if the issue is with this in general, I mean, what I heard you say, I think, is that because of differences in the way the different LME MCOs may be distributing, collecting, and so forth, and the sample size, those two elements, what I heard you say was that it may or may not mean as much as we think it means. So that's what I'm trying to get at. Let's take care of the one element that we can do something about. So, and I think you get the gist of what I'm saying there. That's my motion.
I'll second that.
We have a motion and a second. All in favor, say aye. Okay. So that was unanimous. Is there any other business, Julie, that you're aware of? Anybody?
No.
After that, Pat, you all?
I just need to apologize. I got held up. I guess there's a wreck on 240. I
Oh.
apologize for being late.
There was.
You're
But I'm
fine.
in traffic.
You're fine. Anything else after that?
No, it's good.
Okay.
Good.
Then we'll
Thank you again
adjourn
for
this meeting.
putting up with all of our questions. And
Oh, no,
Yeah.
that's good.
I'm sorry, and I'm
No,
not,
I
and
like
I'm
the
not
discussion.
complaining that you all didn't do your job, not at all.
No, yeah.
It's just that I'm gonna crank out this volume of report.
Yeah.
Let's have it mean something, if we can,
Mhm.
particularly when it's got to do with perception of care. Because if they're not happy about their care, then it's, well, you know what I'm saying.
yeah.
Richard?